moderator, Dr. Narmada Ashok ma'am, faculty for today's session, Dr. Praveen Kumar and Dr. Mukesh Gupta, dear colleagues. So today is auspicious World Health Day, and the theme of this year World Health Day is My Health, My Right. And I think pediatricians are biggest advocate for child right. So we are having today's webinar on pediatric allergy. I would like to request Chairperson Sir, Dr. N.K. Kalpnar Sir, for formal welcome address. N.K. Kalpnar Sir, please.
Yeah, thank you, Dr. Jagdish. At the outset, I take this opportunity to welcome the August faculty for this wonderful event. As you all know, the IAPNRC has got tremendous academic activities. As Dr. Jagdish said, today we have a World Health Day. And in this auspicious day, we are organizing this, one of the non-communicable diseases, which is really need of the hour, and many of our pediatrician colleagues should know about how to identify them, because they are the one who will have a lot of loss of daily life, as well as even it causes a lot of morbidity, especially in childhood. So for this today, we have a very eminent faculties and the moderator. I take this opportunity to welcome first the office bearers of today's IAPNRC, Dr. Sanjeev Singh Rawat, the President-elect 24. And I take this opportunity to welcome the immediate past President, Dr. B.S. Sharma sir, probably in their absence, and Dr. Jagdish Goyal, Secretary, and Dr. Mukesh Gupta, the Treasurer, and all other EB members for this wonderful, the webinar on childhood allergy. So I take this opportunity to welcome the today's moderator, Dr. Narmada Ashok. In spite of her busy schedule, she made it, and she is going to moderate today's sessions. I welcome you on behalf of IAPNRC and myself, madam. I simultaneously take this opportunity to welcome the two eminent faculties. They are the well-known figures, and they are the most eminent personalities in the field of pediatric allergy. That is none other than Dr. Praveen Kumar. Sir, I welcome you for this function.
Thank you, sir.
And I also take opportunity to welcome my colleague, and he is also the treasurer of IAPNRC, and he is the faculty for today's webinar. That is none other than Dr. Mukesh Gupta. I welcome you for this webinar. I take this opportunity to welcome all the senior members and the delegates. I'm sure this is going to be a real eye-opener for you all. And if you make use of whatever the today's faculty going to deliver, I think you will definitely identify many of them, and you will help them definitely in their need. So I wish all the best for today's function. Thank you very much, Jagdish.
Thank you, sir. So just a few words of introduction for today's moderator and faculty. So Dr. Narmada Ashok, as sir told, she is consultant pediatrician at Nalam Medical Center and Hospital, Vellore. And we are having Dr. Mukesh Gupta. He is consultant pediatrician and allergy specialist at Jaipur, and he is also, as sir told, treasurer of IAPNRC. And we are having Praveen Kumar, who is my colleague at he is additional professor at All India Institute of Medical Sciences, Jodhpur, and is pediatric pulmonologist. So without wasting time, I would like to request Dr. Narmada Ashok kindly take over the session. Madam, please.
Thank you so much, Dr. Jagdish, sir, and for the kind words, Dr. Kalpana, sir. IAPNRC, I really thank them for starting this very important workshop on allergy diagnosis. We all know among the non-communicable disease, now the allergy and asthma has become one of the very important issues for childhood, as well as it is also creating a lot of morbidity to them, like the number of absence, the school days absenteeism, as well as the quality of lifestyle for the children is also on the downfall because of this very important problem. Now we have two very eminent persons, Dr. Mukesh and Dr. Praveen, to discuss on this, what a general pediatrician should know about the allergy diagnosis. Quite often it is only the first point of contact is always the general pediatrician, and even when they come to the specialist and the recommendations are given with regard to the inhalers or change in the lifestyle, it is the pediatrician who endorses the specialist view. So it is very ideal, and when we start the treatment early, there are treatments that alter the disease pattern, as well as there are treatments that halt the disease progression also. So it is highly essential that pediatricians are made aware of this important disorder. Hence, I request both the speakers to start it on, and we would be entertaining questions after the session is over, and we would be very happy to clarify the doubts too. So thank you, and I request now Dr. Praveen to start the discussion.
Thank you, ma'am. Thank you, all of you. Is my slide is visible and am I audible? Okay. Thank you. Good evening to all of you. Today I'm going to talk about the pediatric allergy disorder. Why it is important? So there is a challenge in the allergy practice in India. Why? Because there is a lack of allergy training program, the formal allergy training program. There is no NMC recognized courses. However, in the last 1 decade, there are a lot of fellowship and diploma program, which is a very good one and running to compensate this lack of formal training program. I also did the diploma in allergic and asthma from CMC below just in this year coming last year only. Second problem is there is a non-availability of standardized allergens, which is the one of the big problem for us. Third is the allergy testing and allergen specific immunotherapy, though it is available, but it is still not affordable and accessible to the patient in India. And fourth is sometimes if you do the allergy test, especially the blood-based allergy test, cause polysensitization and cross-reactivity, which is again a problem. Which one to thought this is causing real allergy? And fifth, that is the scarcity of local aerobiological data regarding the pollen and fungal spore. Because as we know that allergens exposure is differ between the geographical regions. So it is very important to develop the local aerobiological data, but it is lacking. So today I am going to talk about the introductions, burden of allergy disease in India, how to make a diagnosis for the general pediatricians, and I will talk about some part of the investigation, that is the skin prick test. And then later on, my colleague Dr. Mukesh will carry forward the rest of the investigation and the management of the allergy disorder. So allergy is a group of disorder which is an exaggerated immune response to a substance which is normally innate to most of the people. The main concern is that the allergy is increasing globally, and why it is in both developed and developing countries, and why we will see later on. Clinical presentation of allergy is widely vary from the mild allergic rhinitis to the life-threatening anaphylaxis. The diagnosis is mainly by the detailed clinical history, though physical examination and investigation also help in the making diagnosis, but the history is the main key in the making diagnosis of allergy disorder. Allergy immunotherapy is, now we know that it is effective and it appears promising in the near future. Let's see some of the terminology in allergy. First, hypersensitivity. It is an undesirable, uncomfortable, and damaging reactions which arises from the tissue or cell dysfunction or immune-mediated reactions. And what is allergy? Allergy is an abnormal or exaggerated reaction to the exogenous stimuli. And atopy is actually genetic tendency to develop allergy. And last is the very important term, that is the sensitization. Sensitization is an immunological state which is characterized by presence of a specific IgE on the surface of mast cells. These all four terms appear very close to each other and people often use interchangeable. But if you see closely, they are different terms. And this should be clarified whenever you're making diagnosis or whenever making the terminology for the patient interactions. These four terms are not similar. Now, what is the pathophysiology of allergy? So allergy is a multifactorial. Genetic, environmental, and socioeconomic factors make a very important role in the development as well as persistence of the allergy disorder. In environment, air pollutions, infection, especially the rhinovirus and respiratory syncytial virus, tobacco, smoke exposure, pesticide, diet, like the process will have very important role in the development of allergy. Genetic, we all know allergy has a genetic basis, and it had been shown that if the one parent is involved, then the chances of developing allergy in a child is 20 to 30%. If both parents are involved, the chances of allergy development is 50 to 60%. Another factor is a socioeconomic factor, like the stress, depressions, and the cultural factor. All this together have an impact on the allergy disorder, allergy development, and persistent of symptom of allergy disorder. No, we know that allergy is a type of hypersensitivity reactions. The hypersensitivity reactions for the last 4 decades has been divided into the 4 classifications: type 1, type 2, type 3, type 4. But I want to emphasize the recent update into the hypersensitivity reaction. The European Academy of Allergy, Clinical Immunology have divided into the 9 types. It is based on the inflammation and immune system driven, tissue driven, and direct reaction to the effector cells. And second point I want to emphasize from the new update is that initially we thought allergy is predominantly type 1 reaction. It is true, but other type of hypersensitivity reaction may have some role into the other type of allergy, like in drug allergy, celiac disease, and other type of allergy. So it is true, it is a type 1 is the main type of allergy, but other hypersensitivity reactions may have the pathophysiology basis in the allergy. Now, I will discuss a little bit about that this is the pathophysiology type 1 hypersensitivity reactions. So this picture very well depicts the pathophysiology of the allergy type 1 hypersensitivity reactions. Allergen exposure occur at the site of the skin, lung, gut, eye, nose, and maybe other sites. Allergy reaction usually develop into 2 phases: sensitization phase and effector phase. We all daily exposed to a lot of allergen, but all do not develop allergy. Because of this is the healthy epithelial barrier. Whatever the site of the exposure, this epithelial barrier actually prevent entry of allergen to inside the cells. But somehow, due to the lack or due to the damage of this epithelial barrier, allergen is very smart get entered into the tissue. But we have another level of protection. So these allergen are captured by the antigen presenting cells, process it, and then it present to the and then this antigen presenting cell, like the dendritic cell, will still present to the navy T cells into the lymph node. And depending upon the underlying antigen, it stimulates the navy T cell to differentiate into the type 2 helper cells. And this type 2 helper cells release a lot of cytokines, mainly IL-4, IL-13, IL-9, IL-5, IL-20. And this together, they stimulate the B cell and differentiate into the plasma cell, which are very specialized in secretion of the IgE. That is the IgE, which is specific to this particular allergens. This free IgE bind to the very high sensitive receptor, which is placed on the mast cell and basophils. And once this Ig is bind to the surface receptor on the mast cells and the basophil, it is known as stage of sensitization. Remember, this is itself is not allergy. This is just an immunological stage, and this is not allergy. What happens on a subsequent exposure of the same allergens, it get bind to the IgA surface Ig on the mast cells. This causes coupling of the Ig and a series of reactions, which called decannulation of the mast cells and release a lot of mediator. The predominant one is the histamine. And this lead to the early phase of the allergic reactions, like the increased vascular permeability and airway bronchospasm, increased secretion into the nose and sneezing. And this is known as early phase of the allergic disease. Side by side, there is a accumulation of the cells and the other cytokine release, which cause the late phase of the reactions. So allergy disorder has 2 phases: sensitization phase and effector phase. Sensitization phase itself do not cause allergy. Whenever there is a re-exposure, then cause the sensitization phase to the effector phase, that is the allergy. Next, what is the spectrum of allergy disorders? So allergic disorder, when occurring to the lung and the airway, it causes asthma. This is the bronchospasm, which is dominant by the bronchospasm. In a nose, it causes the allergic rhinitis. In eye, it causes allergic conjunctivitis. in the skin, it causes atopic dermatitis. If it occurs due to the food, it causes food allergy. If it due to the drug, cause drug allergy, venom allergy, and most importantly, that is the life-threatening, that is the anaphylaxis. Apart from that, there are other also allergic reactions, but these are the predominant allergy which occur in children populations. Now, I want to introduce another very important concept into the allergy disorder in children is atopic march. It is the different manifestation of allergy depending upon the age of the child. If you see this graph, the first allergic manifestation is the atopic dermatitis, which occur in the first 1 year of age. And by age of the late childhood, it also be declining and may be absent by the adolescent or in adulthood. After quite a few times, this food allergy usually develop, and it also follow the course like the atopic dermatitis. In the first 3 years, usually the allergic asthma usually develop, and it go to the peak in adolescent, and then depending upon the many factors, it either persist or may decline in the symptom. And to last to develop the symptom of the allergic rhinitis, which the peak occur during the adolescent phase of 15 to 20 years, and then it may persist into the adulthood. So this is a very important concept. Whenever we taking the history, we should ask about the other atopic disorder, which help in the making diagnosis of the child. Now, what is the prevalence of allergic disorder? So as I told earlier, the allergic disorder is increasing worldwide, both in the developed country and developing country. If you take the prevalence of asthma as per the ISAC 3 study, it varies widely. It ranges from the 5 to 8% in the different part of the India. Allergic rhinitis is at approximately 20%. If you take the prevalence of allergic rhinitis in asthma, it may range from 70 to 90%. The prevalence of atopic dermatitis is almost 10%. A very interesting food allergy. The food allergy, when you test for the food allergy, there is a very high incidence of the sensitization, up to 20%. But the very low prevalence of the symptom of the food allergy, which is less than 1% in Indian children. The reason is not known why it is. The sensitization is very high, but the prevalence is very low. And anaphylaxis, there is no accurate data from the India, but the global prevalence of the anaphylaxis range from less than 1% to up to 5%. And the most important fact is that we all know that 20% of the global population lives in India. So you can imagine what is the huge burden of allergy disorder we have in our populations. And we must know about that, and we must try to evaluate it and try to management of such conditions. Why it is more common, why it is increasing in India, there are a lot of risk factors. And we all know India is changing rapidly in a socio-economic front, lifestyle, food habit, and transportations. And this all together causes the increased prevalence of allergic disorder in India, like the Western country. And one of them is very important, a very high burden of air pollution, which is making very important impact on the allergic disorder. Now moving to the how to make the diagnosis of allergy. So diagnosis of allergy is the most important step is the detailed clinical history. History is the most important part of the making diagnosis of allergy. Then physical examination and investigation support the making diagnosis of allergy disorder. Let's first move from the detailed clinical history. And for that, I'm introducing few cases. So this is the case one, says 4-year-old child brought with a complaint of recurrent cough and cold for last 2 months. Mother say it started following a fever episode and the cough seemed to be persistent. The question is, what question we should ask into the history so that we can reach out to the diagnosis, and what are the differential diagnoses in such conditions? Let's start with the history. We should ask first whether the cough is dry or wet. What is the pattern of the symptom? Whether it is occurring, there is a diurnal variation or not. What is the exacerbating factor or relieving factor? What are the trigger which help in the making diagnosis? What is the quality of life? Whether the child is going to school or not, whether going to play or not. This is very important. Response to treatment. We should ask about the previous treatment. What the treatment was given? What was any inhalation therapy given or not? What was the response to the treatment? Whether improved, partially improved or not improved? But neonatal history is also important. Some event into the neonatal period may have an impact on the later childhood respiratory system development, like the BPD, that is the bronchopulmonary dysplasia. And this may confuse with the allergy disorder. So we have to take this particular history apart from the other, like the TTN and the meconium aspiration syndrome. History of atopy in family, as we have seen that atopy in family may run in a family. If the both parents are involved, there may be 50% chances of developing atopy disorder in children. Food habit, again, it is important. And other system involved, it will give a clue to the exclusion of the other disorder as well. Environmental history, which is very important to know what are the particular allergens or trigger which is causing trigger or exacerbation in these cells. The history is very helpful in the making diagnosis, identifying the trigger and driver, and also helping in the grading the severity of the underlying allergy disorder. So it is very important to take the detailed history. It also helps in making differential diagnosis. And we should focus on the red flag signs, especially in the children less than 5 years of age. If there is a history of persistent of signs since infancy, we should think about the congenital malformation or some very much insult during the neonatal period like the BPD. If there's history of weight cup, then it could be other than allergy disorder like the CF, bronchitis, and the protected bacterial bronchitis. If there is history of failure to thrive, it could be due to any chronic disorder, and including the primary immunodeficiency and ciliary disorder. If there is an uncontrolled wheezing despite inhaler therapy, then it could be some pathology in the vocal cord or some vascular ring which compressing the airway. If there is a clubbing, it is maybe due to some chronic respiratory disorder, particularly the suppurative lung disease. If there is loss of weight and mild low-grade fever, then it could be tuberculosis or other chronic respiratory disease. So whenever we making the diagnosis of asthma or any allergy disorder, especially in less than 5 years, we should focus on the red flag sign by taking detailed history. Coming to the second case, she is Ghazal, 7-year-old girl, presented with recurrent sneezing, nasal itching, and running nose. She also has a recurrent cough, itchy rash with erythema, which disappear in less than 24 hours. And this symptom actually occurring for last 1 to 2 years. And the symptom started in rainy and winter season. And these symptoms are usually without fever. She used to take cetirizine with partial improvement in the symptom. So what next? So again, as I told earlier, we have to take detailed clinical history. So we have to ask about what are the detailed symptom durations, their duration, frequency, and severity of the symptom. When do symptoms worsen? Time, place, whether at school or at home or at playground, season, lifestyles. What are the triggering factors like the hostess mite, kitchen, fume, pets in house? Is there any red flag sign present in the child or not? What are the treatment child has taken or what is the response to that treatment? What are the relieving factor? How is the symptom control? It is partially controlled or fully controlled or it is not controlled? Personal history of atopy, any other atopy, any redness of the eye, any food allergy, any snoring or mouth breathing. These all are important to take history in making diagnosis of allergy disorder. Family history of atopy, I have already emphasized on that. Now, diagnosis of allergic rhinitis, as we told, it has 4 cardinal symptoms like the sneezing, itching, rhinorrhea, and nasal block or congestion. If there are more than 2 symptoms are present for more than 1 hour most of the day, you can make a diagnosis of allergic rhinitis on clinical basis. It can occur with or without associated health effect, other feature of atopy, but we need to exclude other disorder as well. Remember, the diagnosis of allergic rhinitis is mainly clinical. So we have to take the detailed clinical history to make the diagnosis as well as to exclude the other related disorder. Now, coming to the physical examinations, if you see carefully, you may get this allergic sign or just in increased blood circulation into the infraorbital regions. It is also known as Denny Morgan fluid. Allergic creases which occur at this boundary of the bony and the cartilage part of the nose at the base of the nose, and this is known as allergic salute. Pale, if you examine the internal part of the nose, you can get the pale and boggy inferior turbinate or inferior turbinate hypertrophy. Sometimes you may get the polyp as well. Further on physical exam, if you take history, you may find the child sleep with the open mouth, and if you somehow you do the lateral X-ray, you may get the this is the adenoid hypertrophy. If you do the examination, you may get the serous otitis media. a child may have the redness of the eye due to the associated allergic rhinitis. If you examine the skin, you may get the finding of the atopic dermatitis. And if the child having any allergy of the airway, you may get the retraction, chest retraction, and the tachypnea. So these are the very important findings which also helping in making diagnosis of allergy disorder, the comorbidity, as well as the severity of the disorder. Now, what is the role of investigation in allergy? So once you make the clinical diagnosis of allergy, suspected allergy disorder, on the basis of detailed history and examinations, look for what is the severity of the symptom. If it is a mild intermittent symptom, there is no need for any investigation. Just give the symptomatic treatment and the follow up the children. But if the child have the moderate to severe symptom or having the persistent symptom, you need to investigate the child. If having the airway symptom like the asthma-like symptom, you may have to do the spirometry. And if there is any, you think a structural abnormality into the airway or maybe in a nose, then you need to examine by the endoscopy or bronchoscopy. And if you excluded this, you need allergic testing, which may help in the making diagnosis. So how the allergy test is helpful in a management of the allergy disorder? It is helpful in the patient education. Once you tell the child is allergic to this disorder, the parent and children understand better way. They better adherence, avoidance, and examination and elimination to the exposure. If there is allergy to the inhalant, we can ask to indoor avoidance like the house dust mites and the mold. If there's an allergen to the cockroach, we can ask for the pest control. If they have the pet, cat, and dog, we can ask for the modification of the home environment. If it is, we have to plan for the immunotherapy, then again, allergy test is very important to document the type of the allergy reactions. And if it is a food allergy, then it also helps in the avoidance of the particular food. If allergy test is negative, even negative, then also helpful in making management because we will then more focus on the irritant, pollution, and diet, etc. So allergy test has overall not only in a diagnosis, but also in the management of the allergy disorder. Now let's come to the what are the common allergens. It could be in an indoor area and could be in the outdoor area. So the common allergen in indoor are mainly four. These are the house dust mite. These are the house dust. They usually reside in the sofa or other soft toys. Cockroach usually in a kitchen, cat, dog, and rat. These are the pet animals except rat. Molds, usually it is not uncommon to find the black sealants, which is known as sealant, into the bathroom and in the dampy area. And they all may cause the allergy either development or the persistence of the symptom. The common allergen in outdoor are the grasses, the pollen from the grasses, weeds, and tree. And it is very important to consider local aerobiology because this outdoor air pollution will vary upon the different geographical region. And it is very important to develop local aerobiology, which help into the management of the child with the allergy disorder. And aerobiology is nothing, it is just to knowing the different outdoor allergen in particular area is known as aerobiology. So these are the few pollens like this is a very common, that is the Bermuda grass, Parthenium, this is the Ricinus, which you all be aware about. These are the allergens, that is the outdoor allergens. The common food, there are 9 common food allergens, though a lot of food can cause allergen, but these are the most common food which cause allergy in children, like the milk, egg, wheat, soybean, peanut, tree nut, fish, shellfish, and sesame. Now, what is the challenge? As we know that there are a lot of allergens. It could be inhalations, it could be food allergens, or it could be outdoor, it could be indoor. So how to select the allergy testing, allergen into the allergic testing? So first of all, it again depends upon the detailed clinical history. If the child having the perennial symptom, then most likely it is due to the indoor allergens, and we need to take into the account house dust mite and as well as the mold. If it is occurring more in the outdoor symptom, more in the outdoor area, then we have to take into account of the pollen and the outdoor molds into the allergy testing. Other challenges in choosing is the coarse tissue and the fixed, because if you do the blood test, that is maybe immunocap or EUROBlot, then they have the fixed panel, which may be difficult and maybe costly also. Available lab and test types are also different in a different lab. There, the value, the margin, the normal range are also reference value also change, and it is very difficult to interpret normal versus abnormal also. So these are the challenges in choosing the allergen for the testing. A few points about the total allergy. This is the simplest test to do the allergy testing. But over time, it has been seen that total allergy is very non-specific. A lot of it cause if you make a diagnosis based on the total allergy, it cause lot of false positive and false negative. And we know that in India, parasitic infection is very common, and this is one of the so it may cause the falsely very high level of total IgE in Indian children. So the message is that to not recommended for the routine allergy screening at your total IgE is not recommended for routine allergy screening as well as in a treatment. So do not rely on the total IgE for making diagnosis of allergy. So what test we have to do? This is the allergy diagnostic test. Either there are two tests, in vivo test and in vitro test. In vivo test is the skin prick test. Other tests like the nasal allergen challenge, but it is not. It is a research purpose, really used for the research purpose, not used for routine diagnosis. And in vitro, it is the blood test, which is the serum specific IgE. Other like the group, there are a lot of Fediatop and immunocap which can be taken into account of large number of allergen at one time. But the most commonly used are the two tests, the skin prick test in vivo and the blood test for the serum specific IgE. How these two studies differ from each other? If you see the risk of the test, it is a negligible in the serum specific IgE, but there is some risk into the skin prick test. If you see the result is immediately available in skin prick test, however, the blood test takes some few times. Antigen selection is a very excellent in a skin prick test, and while it is a good is in serum, that is the specific IgE level. If you see that post, it is very high in comparison to the skin test is a very high. If you see the clinical correlation, it is very excellent in the skin prick test in comparison to the IgE, serum specific IgE. Interference with the medication, yes, in a skin prick test, but it do not interfere into the blood test. Patient perception, it look less scientific, skin prick test, and patients understand it is more scientific. If you look at sensitivity, it has more sensitive than the serum specific IgE level. And if you talk about the specificity, both have very good high specificity. So before doing a test, we should see that what is the difference between the two tests and what is the patient profiles, and then only choose the test, which test you have to do. And one more important thing, what I want to emphasize that they both tests only emphasize that sensitization. The positive result do not make a diagnosis of allergy test. You have to make a clinical correlations, clinical symptom correlation along with the test. Suppose a child having the positive reaction with some other allergens like the parthenium, and which is not in a environment of parthenium, not in environment of the child, then it is not useful to making that his child is allergic to the parthenium. So you have to take into the account in the environmental factor or make to the clinical correlation before making the diagnosis of allergy, basis of the investigations. What is the GINA say on the allergy testing? GINA say that that is the latest 2023 update say that a skin prick test with a common environmental allergen is a simple and rapid to perform. And when performed by the experienced persons with a standardized extract, is inexpensive and a high sensitivity. And regarding the serum specific IgA, it say that it is not more reliable than the skin test, but more also expensive, but maybe preferred over in an uncooperative patient, those with the widespread skin lesion and also having history of anaphylaxis. And if you do the SPT with standardized allergens, it is a gold standard test for the allergy diagnosis. World Allergy Organization say that it is the most accurate diagnostic tool, and it is also regarded as the gold standard for the detection of the IgE levels, IgE antibody. European Academy of Allergy and Clinical Immunology say that a skin test represents the first diagnostic method in a patient with allergic disorder. And the other American Association of Allergy say that a skin prick or puncture test are the preferred technique for the IgE-mediated hypersensitivity. But the catch is that you should have the standardized extract to be making the very strong association with the clinical correlations and this type of test. So what is the skin prick test? It is a very simple. In a skin prick test, we place a small, very small, less than 0.3 microliter, a small drop of the allergen on the surface of the skin, most probably on the forearm, on the back of the back. And with the help of the lancet, we used to prick the skin in a one side, one go. And this gives rise to some reactions which we have to read after the 15 minutes of the prick. You make it the negative control. Apart from that, we have to put the negative control and positive control. In negative control, we take the saline. In positive control, we take histamine. And on the different part of the skin, you have to put the allergens, like here mentioned dust mite and ragweed. And after 15 minutes, you have to see the reactions, whether it is more than 3 mm from the negative value. And sometimes you may get the positive reaction from more than one allergen extract as well. So like here you can see like the horse dust mite and the other, you can also tricad and other grasses, they all have the positive result. The important point is that positive reaction is more than 3 mm above the saline level. Just 3 mm doesn't make it is a positive reaction. It should be above the saline value. Suppose the saline value is 2 mm, then it should be more than 5 mm to making the test is positive. Now, how to interpret the SPT reports? For that, I will discuss two cases here. Here is a 10-year-old child presented with a seasonal allergic rhinitis, most probably in October, in February. He also has exercise-induced breathlessness. He undergo a skin prick test in a pediatrician office. There were no history of any allergy, any drug history. His SPT report was so negative to all the tested allergens and histamine, so 3 to 3 only. So what do you interfere? So here, is this test valid? So before doing this, we have to take the very detailed history, including any treatment history. Any drug which can hamper with the histamine release or any that may interfere with the result. Like if your child have taken antihistaminic in the last 48 to 72 hours, it may interfere with the result. So in this case, on the further study, it has been found that child was on the homeopathic medication on every day. And this medication may contain some antihistaminic which have interfered with the results. So, here the message is that before doing the skin test, you have to take the treatment history also. And the child is taking any antihistaminic, you should stop it 48 to 74 or 22 hours before doing the test. Coming to the another case, this is the last case. A 60-year-old adolescent present with a perennial nasal allergy symptom and itchy rashes. She is not on any histaminic medications. And after doing the skin test, what we find that you give the positive value of 3 into 3 with the negative control, that is with the saline, and about 6 to 7 mm, 6 to 7 mm with histamine. And most of the report you can see here with the horse dust mite, it gives 5 to into 5 mm, and then aspergillus 60 to 7 mm. The question is, how would you interpret this report? What is the relevance of patient having rashes, or is this test is valid? Coming to the first questions. So before interpreting test, we should know the brief clinical history of the patient and condition that is the test is done before the interpreting the test. This test, because the most of the allergens have the positive report as well as the negative saline, so it may occur due to the dermatography's more urticaria. So it could influence the value of the test. So we should take the proper history. If the test is valid, the reaction should be more than 3 mm above the saline value. But here, if you see, all the value are not more than, if you see here alternaria, it is 4 into 4 mm. It is saline value is 3 mm. It is not above the 3 mm from the saline value. So this reaction was just a normal dermatography, or maybe due to the urticaria, it is not positive reactions. So the reaction should be more than 3 mm above the saline value. And if urticaria, need to repeat the test. And if it is not, then the value may be considered if it is more than 3 mm above the saline value. So thank you. Now I invite our colleague Mukesh Gupta to focus or deliver next part of this allergy modules.
So am I audible and visible?
Yes, Dr. Mukesh.
So first of all, thank you, Kalpan sir and Dr. Jagdish Goyal, for giving this opportunity to work on this module and to speak on this module. Thank you, Namda ma'am, for being moderator of the session today. You were my teacher and you taught me the basics of allergy at DAA course at CMC Vellore.
Honored, Dr. Mukesh.
So Dr. Praveen has wonderfully brought out the importance of clinical history, basics of allergy pathology, the type of tests which we can do, and various clinical scenarios of skin prick test evaluation and interpretation. Now in this part, we shall be focusing more on in vitro diagnostics and something on management part. So when do we do in vitro testing? Whenever SPT is not feasible, that means we cannot do skin prick test for various reasons. And what are those reasons can be? When the trained person for doing SPT is not available, whenever there is widespread skin disease, so that you can't find the area where you can test, when the patient is on antihistamine and cannot stop antihistamines or cannot revisit to you, then you can think of doing in vitro testing. When the patient is uncooperative, that means young children who are afraid of pricking, or many females or even many males can be uncooperative. After a recent anaphylaxis, when you cannot do SPT, when the patient is on immunosuppressive therapy and the reactions will be suppressed, then also you cannot do skin prick testing. So these are the various scenarios where you can't do SPT and you have to go for in vitro testing if allergy testing is must. So what are the various kinds of specific IgE allergy tests? In specific IgE testing, we do major antibodies to specific allergen in serum, and these tests are called immunoassays. There are various kinds of immunoassays like ELISA. ELISA is not used nowadays. It's older one, though it's sensitive, but its specificity is very low. Others are fluorescent enzyme immunoassays like ImmunoCap Phardia, which is thought to be gold standard. Usually other blood allergy tests are compared with the ImmunoCap by Phardia. Chemiluminescence or Emulate by the Siemens, ImmunoBlot or EUROSA and EUROBlot are other, and then microarray like LX system. So these tests which we do in blood or serum, they can be performed irrespective of the age of the patient, skin condition, irrespective of the medication status, whether they are taking any histamine or other medication or not, disease activity and pregnancy also. And it is very obvious that they are very safe because there is no other issue except for taking blood sample only. These specific allergy tests can be singleplex versus multiplex. Singleplex means when you are testing for one allergen or single allergen only. And this is for targeted use, and there are limited chance to reveal polysensitized patient because you are doing testing for one allergen only. And serum required for each allergen test will be high if you are doing multiple testing by singleplex method. The results in singleplex method are quantitative. When you are doing multi-parameter tests, it is called multiplex. So you do simultaneous detecting of IgE for many allergens. Here you can find cross reaction, and there are high chances to reveal polysensitization because you are testing for many allergens. And in these testing, serum sample is required is very little one. These are semi-quantitative tests. So EUROBlot is one method where you can test several allergens simultaneously. That is, it is multiplex assay. It is highly sensitive, but the negative part, other positive part is it is cost effective also. So you can test approximately 20 to 25 tests in one go, and cost would be around 5,000 to 7,000. But the problem is the panels are fixed one. So, and many relevant allergens which you want to test may be missing in that panel. The cost of reagents is high as compared to skin prick testing. When we compare in vitro and in vivo allergy testing, Dr. Praveen has already highlighted about the cost, the time taken by the blood testing, the panels which are available in blood testing. Relevant allergens may be missing. Local pollen may not be available in fixed panels which are available in blood testing. And furthermore, they need to be clinically correlated as compared to skin prick testing. So there are several advantages of skin prick testing. However, there are several scenarios where despite having superiority of skin prick testing, we can't do skin prick testing, and you have to go for blood testing only for allergy testing. So we have already discussed these points where we need to go for in vitro testing, like widespread skin disease, when the patient is having dermatographism, patient is on antihistamine drugs, uncooperative patients or young children after a recent anaphylaxis, and the patient is on immunosuppressive therapy, when you cannot be sure of quality of allergens for SPT, when the trained staff is not available, or when you are thinking of going for immunotherapy, then also you may opt for doing blood testing. But the issue is, once you get the reports of this blood testing, how to interpret these results? Because in many scenarios, it may be very tricky to interpret the test results. So we shall be discussing this based on few case scenarios. So coming to case 5, this is a 13-year-old boy who presented with allergic rhinitis and asthma. This boy is a strict vegetarian, and in vitro test was done, and it was positive for so you can see that DF was positive, DP dermatophagoides pteronosinus was also positive. So these both are house dust mite, and shrimp, it was also positive in high values. So shrimp is a seafood. So we need to have this background knowledge that how to interpret this test result. Since this child is vegetarian and they do not consume any non-vegetarian food, and so how do we do this? So we need to know in background that shrimp and prawn, these are the seafood which are cross-reactive with house dust mite. So you may have positive results for shrimp, but actually this is clinically relevant for house dust mite. So this boy is sensitized to house dust mite. So the results of these blood testing are to be interpreted in light of clinical history, as highlighted by Dr. Praveen. One more case scenario, 4-year boy presented with uncontrolled asthma, no GI symptoms, and in vitro testing was done, and the results are as follows. He was positive for multiple food like potato, rice, soya, wheat, and peanut. And if you look at the bottom, grass mix was also very positive, highly. How to interpret in this case again? So here, since there are no GI symptoms, and these food item can be positive due to grass pollen cross reactivity. So this 4-year boy is having allergy to grass pollens. So this background knowledge of aeroallergen cross reactivity with the food and among themselves also is very important to know. Like we discussed that dust mite and cockroach, they cross react with the shellfish. Birch tree pollen can cross react with the peanut, fruits, and soya. Grass pollen with the wheat and other food items also. Tree pollen with the tree nuts. So you may find these cross reactive in various sources available on the net, and these are very important to know and to have in background. Coming to next case, 18-year girl, she was diagnosed as moderate persistent allergic rhinitis based on clinical history. She underwent allergy testing, and all tested allergens are negative. So how do we interpret? So is she allergic or non-allergic? So what is our next action? So it is very important to go back into the history. So we need to check for the diagnosis, whether she is having non-allergic rhinitis or she can be having local allergic rhinitis, where your uh, allergy testing would be negative. We need to check for the selection of allergens, whether the panel of testing which we selected contained all relevant allergen, because many times local pollens which are prevalent in the particular area may be missing in the panel you are testing. We need to check for the quality of allergens used and quality of testing also. Then check for the correct method of performing the test, whether if you are doing skin prick test, then the quality of the lancet, good pricking also. So there are several factors due to which your testing results may be negative in both SPT as well as your blood testing. In allergy testing, the role of total IgE, already Dr. Praveen had mentioned that these are not useful in majority of situations, except like few select situation, like you are planning for omalizumab therapy, etc. So these are not recommended for routine allergy screening or treatment. After doing these testing, how do we manage the patient with allergy? So we will discuss in brief only. The basic principles of allergy management are like avoidance of allergens and irritants, parent and patient education, pharmacotherapy, allergen specific immunotherapy, and follow-up, which is very, very important. So how do we avoid allergens? For house mite, we need to speak to the patient and caregivers that bedsheet should be weekly washed in hot water at 55 degrees Celsius. Avoid furred toys and carpets in the room. Upholstery should not be fur-based, and you need to declutter the house time to time. For the cockroaches, general measures to avoid the cockroach, like eating foods and other eatables inside the bedroom, and use of professional exterminators for removing the cockroach allergen from the house. For fungi, especially indoor fungi, we need to look at the leaking drainage and pipes. They should be repaired. We need to reduce the indoor humidity by improving the ventilation of the house, exposing the house to sunlight. That means opening the windows, removing curtains, etc. Outside should be whitewashed and treated with acetic acid to treat the fungi which is already there on the wall. For the pollen, we need to track the pollen season and counts in the area. For example, if a patient is sensitive to Parthenium, then in the season when Parthenium pollen is there in the air, he or she should not be outdoor as far as possible. Whenever going outdoors, while coming back, we need to clean our clothes. We need to change the clothes, take a bath also. While going outdoors, keep a face mask over the face. If you are going by the car, then keep the windows of the car closed and turn the AC on so that it clears the air. So there are various measures which can be taken for allergen avoidance. Like for pets, removal of the pet from the house is the best and most effective way. We all know about irritant avoidance. We have read them in our asthma training module, and like strict avoidance for smoking inside the home, avoiding second and degree or third degree smoke exposure, avoidance of mosquito coils in home, and also dhoop batti, agarbatti, etc., which cause indoor pollution. Then environmental control measures and can be done by the NGOs and government to reduce the environmental pollution. And we can also do vaccination for influenza and pneumococcal bacteria, so that few of the episode of these allergy exacerbation can be decreased. Patient and parent education is of utmost importance. Parents and older patients should be educated about the nature of allergic disease, the likelihood of disease progression, and the need for long-term treatment. And this likelihood of disease progression, as Dr. Praveen has already mentioned about the allergic or atopic march. So often this part is neglected, and that's why patients are not adherent to therapy. So we need to emphasize this, then to discuss about their goals and expectations for the disease treatment, explain about the avoidance of triggers, how to avoid, and that should be individualized. Explain about the need of intranasal steroid or inhaled corticosteroid depending on the disease and severity, and eliminate the fear of steroid. That is also very, very important. Then to discuss about safety of the treatment modality which we are using. We need to educate and demonstrate the technique of the device each time. So again, very important point, which is often missed, and most of the time for asthma and rhinitis, the cause or root cause for poor control of symptom is due to the poor technique. So that should be checked and rechecked at every visit. Then also to look at the adherence to therapy and effective follow-up. The education to be tailored to the need of the patient, because if the patient is having sensitization or allergy to one allergen, then you should not do general instruction for all the allergen avoidance. So coming to pharmacotherapy, we use antihistamines like oral antihistamine for allergic rhinitis, urticaria, and eczema. We can use inhaled nasal steroid for allergic rhinitis patient, especially moderate to severe rhinitis patient. Then we can use inhalation steroid and bronchodilators for asthma patient. Then emollient, calcineurin inhibitor like tacrolimus, etc. Moisturizers, topical steroid for atopic dermatitis and eczema. Oral steroids as a short course in exacerbation. Leukotriene receptor antagonists for AR asthma, but they should not be used as monotherapy. And we need to look at their side effect also. In many scenarios, when the patient is having anaphylaxis, then we need to train them, explain them about adrenaline injection to be kept ready. Then biologicals whenever there is severe uncontrolled asthma. And the immunotherapy for allergic disease. What is immunotherapy? In immunotherapy, it involves the gradual administration of increasing amounts of the allergen to which the patient is sensitive. So we can modulate the immune response and minimize the symptom. So that means in immunotherapy, we give injection or some sublingual drops to the patient for the same allergens to which he or she is sensitized and having clinical correlation. And by doing this, we modulate the immune system in such a way so that the patient is not having symptoms after a certain period of having immunotherapy. So immunotherapy provides long-term remission, and it reduces the chance of new development of sensitization also. So it is very important, especially in young children. The types of immunotherapy, it can be subcutaneous immunotherapy or sublingual immunotherapy. In subcutaneous immunotherapy, first phase is building phase, when we inject the patient the allergen in increasing quantities to a certain limit, and thereafter we give weekly injections for 3 to 5 years. While in sublingual, it involves the regular self-administration of allergen extract below the tongue, that may be in form of drops or tablet, then it is retained under the tongue for 1 to 2 minutes and then swallowed. It is taken as once daily dose as compared to the subcutaneous, where we can give once every 4 to 6 weeks. So usually adherence is better in subcutaneous as compared to sublingual. But in young children, you may prefer sublingual due to its safety. How do you select patient for immunotherapy? So it is very important. In allergic rhinitis and asthma patient who are having the evidence of IG sensitization with the clinical correlation, you can think of giving immunotherapy. When symptoms are clinically correlating with implicated allergen exposure, symptoms are moderate to severe in case of allergic rhinitis, despite regular and appropriate pharmacotherapy and avoidance strategy. That means allergic rhinitis symptoms are still there with appropriate therapy, then you can think of doing immunotherapy. Those patients who are fed up with the long-term pharmacotherapy for allergic disorders and they are looking for long-term solution. In this scenario also, we should think of allergen immunotherapy. Young children who are having allergic rhinitis, we can give allergen immunotherapy for allergic rhinitis, but also for preventing asthma development. That means we want to prevent the progression of allergic march so that child doesn't develop asthma. When mild to moderate control asthma is there, in those patients we can administer immunotherapy for long-term control and solution for the problem. So coming to few more case scenarios, a 16-year-old boy with mild persistent allergic rhinitis and persistent asthma. He underwent a skin prick test. With good positive and negative control, he showed sensitization to various allergens including house dust mite, DP, DF, Bermuda grass, lamb quarter, mugwort, and 2 other pollens. How do you infer if you want to give immunotherapy? Which are the allergens you will focus your immunotherapy? All or few selected one. So it's very important. So are all allergens clinically significant? Here we need to look again at the clinical history and we need to see the temporal relationship of the symptoms. If the patient is having symptom predominantly during the night time and early morning, that means he or she is having symptoms due to house dust mite. So these temporal relationship and detailed history is important to look at what is the cause for the symptoms of the patient. When patient is having sensitization to multiple pollens, and then we need to clinically correlate with the allergen or pollen calendars. These pollen calendars are available for our country and for various geographic areas also. For example, if a patient is having symptom in the month of Jan or month of November, and his allergy testing is positive for holoptelia, but in the month of November, usually holoptelia may not be a problem. So that means he or she is having symptom to something else. So in these pollen calendars, you can look at like this Poaceae family grass pollens. They usually cause symptom during February to April and then again from August to November. Similarly, Bermuda grass in almost similar season, and lamb quarter again one season only. So if a patient is having symptom in the month of September, October, and his test is positive for lamb quarter, that means his symptoms are not due to lamb quarter. So in such a way, we need to look at the pollen calendar and we need to understand and look at the temporal relationship of the symptom. Should child have immunotherapy for all these allergies? Even if the symptoms are matching with, for example, house dust mite and lamb quarter pollen, then are you willing to give immunotherapy for all the allergens? Perhaps no. So how do we do that? So this is very important concept of allergy threshold. So if a patient is having sensitization or allergy to multiple allergens, even if you treat 1 or 2, then you will reduce the size of this bar and this threshold line will not be crossed. So if you treat 1 or 2, then his symptoms will be reduced because now this bar will be below the threshold line. So this cumulative effect of allergen is known as allergy threshold, and we need to keep in this mind. So whenever we are going for immunotherapy, you should not focus for multiple allergens. This again is very important thing which we are doing and facing in day-to-day practice. You may find various patients with reports, allergy test reports, and such kind of reports you have to look at, and you can see that these reports are usually done between 3 to 5,000 rupees, with tests done almost for 100 to 120 allergens. And you can see that in this report, turmeric and vinegar was tested. Similarly, salt was also tested. Then MSG or Ajinomoto was also tested. And the results are almost similar. Then also tested for contact allergens, for drugs also tested in one go only. So we need to be aware of these type of fake reports. These are totally unreliable and mesh. Coming to component dissolved diagnostic, this is newer testing methods which are not available easily in our country as of now. But CRD may be the future of allergy testing. But today, usually they are not needed in majority of clinical scenarios. What is component dissolved diagnostics? Each allergen is having multiple components of allergens, and these components are known as epitopes. And these all epitopes are not significant clinically. Few epitopes are very important while others are not. In component dissolved diagnostic, we test for these multiple epitopes, and we can look at the cross reactivity. We can look at what are the foods which are having cross reactivity, and we can know that what food is or what food component is actually causing problem. So CRD is next stage of testing, which is not required in day-to-day practice, but maybe for allergy specialists in coming years. When patient is having polysensitization, like for pollens, then what to treat. So we can know the which component is most important and positive for the patient. We can treat for that allergen by allergen immunotherapy. So in CRD is important in complex situations. Coming to drug allergy, if you look at drug allergy, majority of adverse reaction to drugs, these are non-allergic. Only few adverse reaction to drugs are allergic type 1 reactions. Atopy is not a predisposition to drug allergy. Detailed history about culprit drug, dose, route, duration, and chronology of administration and onset of symptoms, concurrent drugs, patient and disease details shall indicate possible mechanism. So if you take the detailed history and temporal relationship of the symptoms, then you can reasonably reach to one or two drugs causing the symptoms. There is no role of routine or prophylactic drug allergy testing, because we all know that to have allergy which is IgE mediated, we need to have initial few exposures to develop the sensitization. So if a patient is not sensitized to any drug, there should be no value of prophylactic drug allergy testing. So these drug hypersensitivity reactions can be drug allergy or non-allergic hypersensitivity. Drug allergy can be IgE mediated or they can be non-IgE mediated also. How do we differentiate between these two? By the temporal association. Usually IgE mediated reaction will happen within less than 1 to 2 hours of administration of the drug. While in non-IgE mediated, symptom onset is usually after few hours. Symptom onset within minutes to few hours in IgE, and the symptoms are like urticaria, angioedema, respiratory symptom, and abdominal pains. And in rare situations, anaphylaxis. These can all happen in IgE mediated. While in non-IgE mediated are like skin manifestation of SJS, toxic epidermal necrosis, Brest syndrome, etc., liver dysfunction, etc. Usually there is no anaphylaxis, but systemic symptoms may be debilitating, which may occur after 12 to 24 hours later. The mechanisms behind non-IgE mediated drug hypersensitivity reactions are type 2, 3, or 4 type of hypersensitivity reactions. One word about patch testing. Patch testing is usually done for contact dermatitis in children 6 years and above. Allergen selection depends on the exposure to the chemicals or drugs or allergens. Exposure and substance encountered in common daily activities, like if I am using some body lotion, then the components of body lotion we can test. Similarly, if a patient is having allergy in the neck at necklace area, then we can test for some metals. In such a way, patch testing is useful only for contact dermatitis. So coming to the end of this module today, we should summarize. Detailed clinical history should drive the allergy test to be done, and this is very beautifully highlighted by Dr. Praveen. History and history again, before test and after test. Select allergens carefully based on the history. So when you are doing allergy testing, you do not test for long list of allergens like 30, 40 or 50 allergens. Rather, you should select only few relevant allergens, usually less than 10 in young children, and even you may screen for 1 to 2 allergens when clinical history suggests so. Choose the right test and right method for testing. SPT is the gold standard for allergy testing because it is more sensitive. Both SPT and serum specific IgE, they correlate well for diagnosis of allergies. The presence of specific IgE by SPT or blood testing, they does not necessarily indicate clinical allergy. Clinical correlation is the most important criteria irrespective of the test values. Cross-reactivity is to be kept in mind while interpreting the results, as we have seen in few case scenarios. For drug allergy testing, serum Ig is not reliable. Skin prick testing with non-irritant concentration of the drug should be done. Patch testing is helpful in contact dermatitis. So this was all about the allergy diagnosis. Thank you. Thank you very much. And over to Dr. Jagdish.
Yeah.
Can you take questions?
Yeah. I think there are two
You
questions.
can stop sharing, yeah.
So Denny Morgan fold is due to, somebody has asked us. I think Dr. Praveen or Dr. Mukesh can take this question. In allergic rhinitis, we get the Denny Morgan fold. So
Okay. So Danny Morgan fold is actually a skin fold just below the inferior eyelids, and it happened due to the chronic inflammation of the eye, which make the skin little bit thin and more delicate, so that it give the fold-like a structure below the inferior eyelids. It is not specific to just to allergic rhinitis. Even in eczema, atopic dermatitis, you may find it. Even sometimes it is a genetic predisposition, also sometimes you may find it. But if you get it along with other symptom, it is indicative of some allergic rhinitis as well as atopic dermatitis.
So the next question is that's if an allergy needs a sensitization phase before manifestation. So if a patient is allergic to peanuts, he may not have hypersensitivity at the first time he's exposed, or he may still react.
Okay, so first of all, I want to again emphasize that allergy by and large is a type 1 reaction, that is the immune mediated reaction, but it also occurs in other hypersensitivity reaction. In type 1 immune mediated reaction, there are two phases, sensitization and the effective phase. Or in a sensitization phase, it is just IgE which bind to the surface of the mast cells and the basophil. There is no degranulation, there is no any release of the chemical. So there is no actually symptom of the allergy. Once there is a re-exposure of the same allergens, it bind to the antigen binding site of the total IgE.
I do understand.
Two molecule of IgE, and then it got coupling and the series of reactions which release the degranulations.
Dr. Praveen, I think what he's meaning is, in case of certain patients, the food allergy patients, even in first exposure of the infection, exposure of the allergen, they may develop severe anaphylactic reaction. That's what he means. Yes, it is very much possible for them to develop. though there is a though we talk about the sensitization phase and the clinical reaction phase, case of a food allergy, even at the first time, they may get a very severe reaction, which may cause anaphylaxis. So it is completely possible. So what we are talking about is we don't know when the sensitization would have occurred, or the first episode itself would be an anaphylactic episode. So this is what he's been talking about is the routine allergy episode. So it is quite possible of the scenario which the question has been asked.
So may I add something?
Yeah, please.
So in Western world, like in US, they use peanut butter and in lot many things. So in cooking also they use. So it is said that the patient is exposed to peanut by aero inhalation, then also he may be sensitized. So it is not necessary to have first exposure by GI route. Even if he is exposed by skin or by respiratory mucosa, then also patient may be exposed. So that may be the reason for having symptoms due to first exposure or first ingestion.
Yeah. So they also wanted to know about the measurement of SPT or a serum specific IgE are recommended as a first line test to support diagnosis of IgE mediated food allergy by Yaki 23. Yes, definitely that is one of the things. When there is a strong history of suspicion, history is there, suggestive of food allergy, we usually, we know, and the only food avoidance is the best. But when there is a doubtful history and you really need a confirmation of the presence of the food allergy, because that was beautifully explained by Dr. Praveen. He said that sensitization is just a clinical immunological phenomenon. We need the clinical correlation of the history. So doing the serum specific IgE, when there is an inner background of a history and demonstration of the same will tell you that the patient is definitely going to have the reaction. So the food allergy, when there is a history, which is like you have multiple foods that has been eaten on the same time and you have a doubt, you might do it. But when there is a strong clinical suspicion, you will have to take that into consideration. So I have 2 or 3 points which has to be added to whatever the beautiful presentation which has already been given by both Dr. Praveen and Mukesh. That was rightly quite an exhaustive presentation which comprised all the aspects of allergy, but it has been really put forward in a very, very simple way too. So one thing is that I wanted to tell you about the difference between the skin testing and the serum specific IgE. The serum specific IgE generally measures about the free IgE, where the skin specific IgE measures the bound IgE, and that's the reason it is more clinically relevant. One thing. Second thing, and we are talking about the standardized allergen. Standardized allergen actually means the number of the quantity of the every major allergens that is in the allergen preparations they have made. So in US, usually we have and international, they have a national standardization where each company is required to show that the major allergen is on par with their national standard. But whereas in Europe and even in India, we have only an internal standardization where the company has its own standard preparation procedure, and then it compares against the same. So what happens when you're using a standardized allergen, internationally, we can use the same allergen. Whereas in this case of when we are using in India and Europe, what really happens is you will have to use the same allergen both for testing as well as when you're going to use for immunotherapy. There may be a component of batch to batch variability. That's the only difference. But then in food allergy or when compared to the Indian pollens, we do not need to be worried about the standardization because even the prick to prick testing is very much useful. So standardized allergen, the absence of standardized allergen does not mean that you are inferior in your testing. So don't worry about that. As of now, the US alone has about 14 to 18 standardized allergen, whereas Europe are still developing it. So don't worry about that. Then when compared to the polysensitization, you talked about the component resolved diagnostics, right? The CRD is very helpful for us in this particular condition because component resolved diagnostics clearly tells that whether the particular antigen, the marker antigen is being there. See, for example, a patient might be developing a sensitivity to very beautifully explained by that thing, dust mite and shrimp. He's a vegetarian and he was never exposed to shrimp, but he had a very high positivity in skin prick test when he did the shrimp. So this was a cross-reactive antigen. So CRD, when we do, we will know that the dust mite allergen, some of the protein has been cross-reactive with the shrimp protein. So in CRD, we'll get the specific protein. So that is where CRD is being used. And it is going to be the future. For example, even in insect venom hypersensitivity, when we are having multiple, when we have the patient might be allergic to bee venom and as well as will show sensitization to wasp or hornets also. At that condition, they have the antigen, the specific proteins for the bee venom. It can be clearly found out by the CRD. But the only problem in CRD, one is the cost factor, but of course it is coming up in many centers now. The second thing, the allergy person only can interpret it. They will know the specific protein for each of the species. So component resolved diagnostics needs a more of your knowledge on the particular protein that is you're being particular allergen is there. You need to know the component protein here. So the third thing I wanted to know about is the two things he brought about very clearly about allergic rhinitis. Always you have to approach allergy as a multi-system disorder. It's not a single thing. You should not look only at the symptoms. You should look at every other factors also, and never miss on allergic rhinitis. In the study done in Vellore by me, I found out that 98% of the children were having allergic rhinitis and asthma together. And this has been really high to about 75% in most of the studies done across India. And the another factor he really beautifully highlighted is otitis media. And as a pediatrician, this is one of the comorbid feature in every child in asthma and allergic rhinitis we have to be looking at. So this was what, and skin prick test not only helps us for the prognostication, it's also for the phenotypic classification, because we are now more and more going into a very personalized management of asthma. So for us to find that it is a atopic asthma, for us to know what they're sensitive to for the environmental thing. So skin prick test, I would have a high, even for a mild case, if there is a heavy disability, if there is a morbidity in their lifestyle, I would go ahead and do the investigations more. So drug allergy itself is a very big topic. So we have just touched on it. Probably it's a sensitizer to the drug allergy chapter. We need a more detailed discussion on it. Anyway, congrats to both the speakers and for IAPNRC chapter for taking this very important sensitization topic, I would say. We will require more of detailed discussions on the same. I think, oh God, there's so much questions have come up now.
Yeah.
What's the lowest age at which SPT can be done? Mukesh, your take on that?
So I think since IgE can be produced in intrauterine life, so perhaps theoretically we can do in neonates also. At the earliest age of 3 months, I have done SPT and it was positive for milk. And
yeah, the only difference, the only two things is, one is the parents might not be very comfortable. Yes. We usually prefer to do it in the back. And second, the allergens which you use should be very minimal only. You should be having a very high chloride. So probably in 3 months, you would look at not the drug, dust mite or anything. You would just do the saline, histamine and the milk allergy. You have done it for the food allergy, right? So only these three. Yes. So how can we desensitize any food allergy? Rinkisha, I think the best thing is avoidance in the food allergy only. Then children outgrow certain food allergy. For example, egg and milk, they usually outgrow by about 5 to 6 years. Of course, nuts, they never outgrow. So there is no desensitization. And again, here the CRD actually helps. So in case of a nut allergy, we can find there are ARA H1, H2, H3 antigen that are capable of producing anaphylaxis. There are less common, that they will show sensitivity in skin tests to certain proteins that are not life-threatening. So in that condition, CRD can help and you can reassure the patient. But desensitization to food allergy, I don't know, but food immunotherapy is coming up the same. And should we advise elimination? Yes, elimination is the best way if it can be avoided. So Mukesh, this is for you. What is the role of combined drug, example like antihistamine with montelukast in the management of AR?
So no role. It is not recommended. We should use them separately if they are indicated. Montelukast is not being recommended nowadays. There is box warning of US FDA for the Montelukast. It should not be used for long term. And antihistamines also usually be used for 1 to 2 weeks for allergic rhinitis. Because if the rhinitis is persistent, then we use intranasal steroid. So combination is not warranted in both asthma and rhinitis also.
Rhinitis, yes. And the pharmacokinetics is very different from montelukast. And we do not want to use montelukast for a very longer time, especially in seizure disorder or in autistic children or hyperactivity. We have to rethink about the same. Dr. Praveen, can you take this recommended treatment for allergic conjunctivitis?
Yeah, it is a recommended treatment for the allergic conjunctivitis, olapatadine. There are also a type of antihistaminic which act locally.
Yeah. Okay.
But it should be remembered that sometimes this allergic conjunctivitis is actually feature of the allergic rhinitis. So they may happen together. So if you treat the allergic rhinitis, this will also taken care of that.
Or steroid drops or an
also oral histamine. Yes, ma'am.
The cross-reactivity chances in SPT, that's what we were discussing. There are high chances of cross-reactivity. It can also be due to carbohydrate, the CCD determinant. So SPT, overall, it can produce, so in the background of a clinical history, we will interpret the SPT, as well as if you want to be very specific, CRD helps in this way. And elaborate on an immunomodulator like omalizumab. Any of the speakers can take it.
Praveen, you would like to take? I have not used omalizumab, and I think I will not need for next 10, 20 years. So actually, there would be very limited situations when you need omalizumab.
Right. So the thing is that anti-IgE omalizumab has been used in combination with immunotherapy also. Certain adult patients, definitely when the IgE levels are high and it is not due to fungal sensitization, omalizumab has helped. So it's not like but the thing is that in children, we need more experience on the same. And then whenever we are classifying any child as a difficult to treat asthma, we need to look more into whether the technique most commonly the technique and the diagnosis only we have to revisit. But in an adult, they have been using omalizumab and have found excellent results with the same. So, and how to interpret in an SPT in case of a negative control, you do not interpret. Negative control is always less than 3 millimeters. This I've been repeatedly telling. And positive control is 3 millimeters above the saline. So if there is any discrepancy in this, we do not interpret. And again, allergy skin test is not like an emergency situation. You do not need to give an answer. You can ask them to come back after 15 days when the skin reactivity has come down. So should kindly touch on treatment. I think he just did a basic on allergy rhinitis. As I said, this topic is only a sensitizer. You need to dwell more into it. And then again, thing is, subcutaneous testing should be done before giving injection ceftriaxone. In drug allergy, it's a no, complete no. All the guidelines are very clearly telling it. If you have a history, you will go ahead and avoid the injections whenever is it possible. And if that is, if you do not do it as a prophylactic, drug allergy testing is not done as a prophylaxis. You do not do it before any perioperative procedure. You need to have a history in order to investigate of the same. And he has clearly mentioned non-irritant concentration is done in the background of a history suggestive of a drug allergy in order to prove that reaction. We do not do a prophylactic testing for drug allergy. That was a real nice interaction from everybody, I think, at the last. Yeah. Okay, shall we close it, Dr. Jagdish?
Yeah. So on behalf of IAPNRC, I would like to thank moderator and both the faculty for sparing their time and all the attendees who have attended this important webinar just to sensitize for allergy. And I would also like to thank our sponsor, CPC Our Life, who provided academic grant to conduct this webinar, and our IT team for making this webinar possible, Mr. Adarsh and Mr. Rahul. So thank you, everyone. We would be having next
if there
webinar
is time,
probably on.
Two people have raised their hand, Dr. Shirish and one more person. If there is time, you can permit it.
Actually, 5:30 is the
5:30.
time, and we
Okay.
So if you are having any questions, any suggestions regarding this module, you can send an email to Secretary Respiratory Chapter at Secretary Respiratory Chapter at gmail.com. If you are having any suggestion, any correction, or any addition, so you are all welcome. And thank you once again. And we would be having probably next webinar on World Asthma Day. Till then, goodbye. Thank you. Thank you.
We have to also remind about the midterm Respicon. Some request has come from the organizers.
Yeah. So we are having midterm Respicon in Pune in the month of June. So all of you are requested to register and attend the. Any sir closing remark from you, Chairperson sir?
No. It was indeed a great session. I was listening completely, and all the moderator and the speakers did extremely good job. And they made sure that, the take-home messages were very clear. And it was needed very badly for our practicing pediatricians so that they can touch upon this and they can identify and definitely help the needy patients. Thank you very much for this wonderful sessions, both moderator and the speakers.
Thank you, sir.
Thank you, sir. Thank you, everyone.
Thank you.
Thank you.
So with this, we conclude this session. Thank you very much.
Thank you. Congrats to the speakers.
Thank you, madam. You're a student only here. Thank you.